Thank you, Twyla. I failed to introduce myself at the beginning. My name is Judson Hill. I'm a senator in Georgia. Honored to be able to be a part of this panel and moderate today. And thank you. I know a lot of you here, and I appreciate and value your leadership in healthcare across this country, what you're individually doing, and collectively what we can do to bring more free market, patient-centered reforms to this country, especially in light of what's happened at the national level for the last few years. Our next speaker is Michael Tanner, who's a senior fellow at the Cato Institute. He heads research into a variety of domestic policies with particular emphasis on healthcare reform, welfare policy, and Social Security. His most recent white paper, Bad Medicine, A Guide to the Real Costs and Consequences of the New Healthcare Law, provides a detailed examination of the Patient Protection and Affordable Care Act, some have called Obamacare, and what it means to taxpayers, workers, physicians, and patients. I've read it, and I commend that article to you. It provides a lot of valuable information that I think is worthwhile for each one of us. Michael's writings have appeared in nearly every major American newspaper, including the New York Times, Washington Post, Los Angeles Times, the Wall Street Journal, and USA Today. Before joining Cato in 1993, I'm thankful and honored to say and let you know that Michael served as the Director of Research at the Georgia Public Policy Foundation, which does some great work there in the state and has continued to do so since 1993, and as Legislative Director for our one and only ALEC. With that, Michael, welcome and thank you, and we look forward to hearing your remarks today. Thank you.
Well, thank you very much, and I know that the citizens of Georgia are thrilled to have you tackling health care down there, and I'm thrilled to be back among friends at ALEC. I really appreciate it. I never actually thought that at an ALEC panel I would be the designated squish on these issues. But the fact is, I don't hate comparative effectiveness research. I really don't. I think it has its place. To say otherwise is to suggest that healthcare resources are virtually unlimited, and that we shouldn't try to determine what is the most effective use of those resources, or to suggest that physicians always have the knowledge and the ability to designate, to do exactly what is correct in every situation, and we know they don't. They react to a variety of other things, including the way they were trained and so on. It is a literal fact that if you're pregnant and you land in Tampa, Florida, whether or not you have a C-section depends on whether you turn left or right when you leave the airport. There's two hospitals down there, and one of them has a C-section rate of over 60%, and one of them has a very minuscule C-section rate. And it's because the doctors in the two hospitals are taught different things. In one hospital, they're taught the first sign of trouble, you immediately do a C-section. And in the other hospital, they're taught, no, avoid C-sections because they have these other problems or whatever. There doesn't appear to be any difference, particularly in outcomes, but they're taught very different things. Similarly, back surgery. Between the East Coast and the West Coast. I sometimes get this wrong, but the West Coast physicians that tend to do back surgeries, East Coast physicians tend not to, because of the way medical schools on the two coasts train their physicians. Again, there does not appear to be a significant difference in outcomes. It has to do with those sort of lines of training that older doctors teach younger doctors the way they were taught, and that seems to get passed down. Knowing what are the results of back surgery might be useful. Knowing what are the complications that go with C-sections, when should you have them, when should you not have them, strikes me as being something that would be useful to know. Now, there are certain things you need to be cautious of when you do comparative effectiveness research. The first, as Twyla told you, is this whole definition of quality, which is not a unidimensional phenomenon. In fact, it is very, as she pointed out, very idiosyncratic. And I'll just give you one example that you know, men in the audience certainly can appreciate. If you ever have prostate cancer, there's a variety of treatments. And I can tell you, if you go to a surgeon, the surgeon will tell you that the only effective treatment for prostate cancer is a radical prostatectomy. It's the only thing that has a 100% 20-year survival rate. So they'll say you have to do that, no doubt about it. Now, there are these side effects that go with radical prostatectomy, but they sort of disregard that, you know, because they're into the 100% cure rate. You can go to other doctors who will tell you, well, there's brachytherapy, the radioactive seeds, there's electronic beam radiation, there's different other therapies, whatever. Now they only have about 98 97% survival rate over 20 years, but their chances of the side effects are far diminished. Which of those is right? You know, do we want a single entity saying, well, you have to do the surgery, or because, you know, we're going to measure only on survival rates, or we're going to, you know, take the other into account and say, well, you can't have the surgery because the side effects are, or do you want people to be able to choose? So you got to be a little bit careful, you know, about defining quality, as you heard. Second, most comparative effectiveness research tends to look towards the mean or towards an average patient. And when you have patients who are outliers, you know, you can't necessarily apply. It's not necessarily just plug in and do the cookbook thing. You know, knowing what the cookbook says is useful, but you can't necessarily apply it rigidly across the board. And third, it does create delays with new equipment, new technology, and so on, because they have to go through, if you want, you know, expect them to go through this process and everything before they're widely reimbursed. And the biggest problem of all comes when the government begins to do not just comparative effectiveness, but cost effectiveness research. And that's when you get into values judgments, not things that are sort of scientifically testable. And yes, there's a lot of problems with what is the evidence, and not all of the, you know, you really have to dig into a lot of these studies to find out whether or not they're good evidence-based research or not. But there's a difference between that and the sort of value judgments that go with cost effectiveness research. I mean, if you just think of this type of things, when we say that this procedure is not cost effective, well, cost effective compared to what? Are we suggesting that it's not cost effective because the resources could be used better elsewhere? Well, you know, what about, what kind of judgments are we making in that case? Is saving the life of one person with those resources a better use of those resources than improving the quality of life for 20 other people? You know, how do we make those sorts of value judgments? And by definition, as soon as you get into this sort of cost-effectiveness research, which can lead to rationing, you begin to make those decisions. So I think you need to be very cautious that you go down that road. That said, there's really no reason for the government to get involved. The private sector is undertaking cost-effectiveness research. Most insurance companies undertake this in determining what they reimburse for. They don't reimburse for every procedure, nor should they. So this, you know, because someone comes up with a new experimental procedure and says, we want to try this, it's going to cost $1 million on this patient, we're not sure if it's going to work or not, but we're going to submit the bill to the insurance company. Should the insurance company have to cover it? You know, no. And they do this sort of research, and they determine we're not going to, you know, if you want to bring in a shaman and, you know, and have him do things for you, we're not necessarily going to cut that under our insurance plan, unless you're in California, in which case we'll mandate it. But you know, they make those sorts of decisions. There are all other private groups that are out there that are doing this sort of research and then selling the research to insurance companies and others that are using this. There is a host of competing comparative effectiveness research. And this then, like with all other goods and services we know in the marketplace, is actually what produces the quality and the most usefulness of it, the competition among these. People can look at these different studies and say, you know, this group over here, well, they don't do a very good job. You know, they've been you know, on the payroll of the pharmaceutical industry for a long time, and surprised that, you know, this study was funded by pharmaceutical company X, and amazingly, it found that their new drug always works better than the competition's drug. You know, you could find that out, and then you say, we won't use them anymore. We'll use this other group over here, and things like that when you have that wide variety of competition. People who look to the government think that the government can somehow avoid this, and you know, this is just basic silliness. The government, yes, can, you know, is subject to all sorts of political pressures in its comparative effectiveness research. The clearest example is anybody here from Oregon? Anybody represented from Oregon? Oregon actually is the test case for this. Several years ago, Oregon came up with, I thought was actually a pretty reasonable idea at the time. They had a Medicaid program, and the Medicaid program couldn't reach all the poor people in Oregon. There just simply wasn't enough money to fund all the people who there. So what they said is, in order to make this go further, what we're going to do is, instead of giving all the money to a handful of people, we're going to do some comparative effectiveness research, and we're going to decide what treatments Oregon's Medicaid program will pay for on the basis of what is the most effective. And they went through hearings, and they brought in the experts, and the scientists testified, and the doctors testified, and everybody, and they came up with what was a pretty good list. And they listed, I think it was 400 and some odd procedures in rank order. And starting at the bottom, they said,